Dr. Rashmin, please.
Thank you, Dr. Mukesh. So there has been a little change in schedule, and we'll see if we also continue in the afternoon with neuro-ophthalmology. But let's look at some of the localizing signs that you may find in neuro-ophthalmology. So this is scenario number 1. What do you see here, and where would you localize the lesion? Is this bitemporal or binasal? Doesn't it look like binasal? This is binasal. What do you think? Yeah, black is a field effect, but is it on nasal side or temporal side? Binasal, correct? Right? How many of you say that this is binasal? Raise your hands. Yeah, this is binasal. So rest of you are saying that this is bitemporal, and it is bitemporal hemianopia. How do you come to that conclusion? Why it is bitemporal? What do you find generally on a temporal side is a blind spot. Blind spot is because of the optic disc, where you don't have any vision. So optic disc is nasal in your fundus, so it produces a blind spot which is temporal. Here you're not seeing any blind spot, so this is a bitemporal hemianopia. Question is, where do you localize the lesion? If you find a patient with bitemporal hemianopia, where is the lesion? Yeah, so you're looking at probably a chiasmal compression, right? So bitemporal hemianopia, generally patient will have chiasmal compression. The question is now, what are the other features that you look for if somebody has chiasmal compression? What are the other neuro-ophthalmic findings that you look for? What will you find in fundus in these patients? Would you find anything, any sign on the fundus examination? So you have a dense temporal defect, right? Dense temporal defect meaning which fibers in the fundus are not functioning? Nasal fibers. Nasal fibers serve the temporal visual fields, and temporal fibers would serve the nasal visual field. So nasal fibers are not functioning. Nasal to what? When you say nasal fibers are not functioning in these patients because they have a dense bitemporal hemianopia, nasal to what landmark? Nasal to macula. Absolutely right. So fibers nasal to macula would not be functioning because patient has bitemporal hemianopia. Clear? So the nasal fibers, imagine that if there is an optic disc here and if there is a macula here, the nasal fibers go like this. What are they called? From macula to the disc? Papilomacular bundle. So they come and get attached on the horizontal part of the disc. Similarly, the nasal fibers also come and get attached here. All right? So the nasal fibers which are affected in this bitemporal hemianopia, they are attached on the horizontal part of the optic disc. The poles, superior and inferior pole, what fibers get attached there? Arcuate fibers. They get affected first in what disease? Glaucoma. That's the reason why you find arcuate scotoma in glaucoma as one of the signs. So here, in this patient, bitemporal hemianopia, fibers get attached to the horizontal part of the disc. So the horizontal part of the disc will become pale. Superior and inferior pole will not become pale initially. So in the fundus in this patient, you will find a band-shaped optic atrophy or a bow tie optic atrophy. You know the bow tie is horizontal like this. So in the fundus in these patients, you'll find bow tie optic atrophy. So that's another associated feature. Anything else? You're talking about bitemporal hemianopia. You have localized the lesion to optic chiasm. Now we are saying what are the other features that you are looking for. One feature we looked for is bow tie or band-shaped optic atrophy. Anything else that you can look for or you'll find in these patients? If you check ocular motility, what will you find? One particular type of nystagmus. Seesaw nystagmus of Maddox. So that's the other associated feature of somebody who has a chiasmal compression. The most common obviously is bitemporal hemianopia. The other associated features would be a bow tie optic atrophy, and that occurs because the nasal fibers get attached to in the horizontal part and they are not functioning in these patients. Seesaw nystagmus of Maddox. There are two other signs that you need to remember. This can be a short note, and that's the reason why I'm covering these. There are two other signs that you'll find in somebody who has a bitemporal hemianopia because of chiasmal compression. One is called post-fixational blindness. So what happens is that if I'm looking at a pointer here, everything beyond, so I'm converging, everything beyond the point of fixation falls on my temporal visual fields, right? Because I'm converging here I'm looking at the pointer, everything beyond that falls on my temporal visual fields. In these patients who has chiasmal compression, both the temporal visual fields are not functioning. So patient would complain typically of not seeing anything beyond a point of fixation. And that's why it's called post-fixational blindness. So that's the other associated sign in somebody who has a chiasmal compression. And the last sign that you should remember is called hemifield slide phenomena. So what is hemifield slide phenomena? You see here, this is a temporal part of the left eye. So in the retina, you've heard of retinal correspondence. You know, retinal correspondence is important for binocular vision. So point here would have on a temporal part of the left eye, would have a corresponding point where? In the right eye, where would the corresponding point be? On the nasal half. So what is happening here is because both temporal fields have gone, the corresponding point of this is gone. Corresponding point of this is gone. So there is less incentive for fusion and binocular vision. So if somebody who has phoria would immediately get converted into tropia, and that is called hemifield slide phenomena. So we started with bitemporal hemianopia. We localized the lesion to optic chiasm. Most common optic chiasm lesion producing this kind of defect is chiasmal compression. And associated features would be bow tie optic atrophy on the fundus, seesaw nystagmus, post-fixational blindness, and hemifield slide phenomena. Is that clear so far? Okay, so we move on to the second field. Okay, so this is how generally you will find the fields in your normal day-to-day practice. It's very rare for you to have a clear-cut textbook kind of fields. So who will read this field? Which eye is this? Right or left? You have 50% chance of being right. So let's say right or left? Left or right? I can't still hear. Somebody is saying left. Can you see a blind spot here? Yeah. So this is the temporal part. This is a left eye. Okay, and this is the right eye. Okay. What you're finding here in the right eye? There is a complete depression of visual field, right? So complete depression of visual field generally tells you that optic nerve is not functioning. There are several visual field defects which you localize to optic nerve. They are central scotoma, centrocecal scotoma, generalized reduction of sensitivity, complete depression of visual field, or arcuate scotoma. All these you localize generally to the optic nerve lesion, also the altitudinal defect. So you see here, there is a complete depression of the right visual field. So you assume that maybe the right optic nerve is not functioning. Clear? What is happening with the left eye? I said that this is a blind spot. Okay, this is a blind spot of the left eye. So what do you see here? There is a defect here. So that will become a temporal defect or a nasal defect? Because blind spot is temporal, so this is a temporal defect. So what you find here now is an optic nerve, complete optic nerve depression of the right side and a supratemporal defect of the left side. Where would you localize the lesion? What is this field defect called? Junctional scotoma. Please remember there is a field defect called junctional scotoma where you will find an optic nerve type of disease field defect in one eye and a supratemporal defect in the contralateral eye. So if you find an optic nerve kind of defect, a central scotoma or a generalized reduction of sensitivity, look at the other eye field supratemporal defect very carefully because this again would localize to chiasm. This also is a sign of a chiasmal compression, especially when chiasm is little prefixed, is where you will find that one eye optic nerve is completely compressed with the tumor and the other eye has a supratemporal defect. Clear? So this is a junctional scotoma, again localizing a lesion to optic chiasm. We spoke about what are the other defects that you may find in these patients. All right, one more visual field for you to analyze. Okay, first let's go to the basic. This is right eye or left eye? Come on, right or left? Left eye. Why? Because the blind spot is not seen, and this is a so this defect is temporal or nasal? So there is a left eye temporal defect. Is it respecting any midline? Yeah, so there is a dense temporal defect of the left eye which is respecting a vertical midline. Everybody agreeing to that? Okay, now this is a right eye. What do you see in the right eye? You see some defect here superiorly and some defect inferiorly. So let's for a moment ignore this defect. We are ignoring a superior defect and we are only concentrating on inferior defect. So again, is the inferior defect of the left side, is it respecting a particular line? It is respecting a vertical midline. So for a moment, if you are ignoring this defect, what you have is a temporal defect of the left side, also a temporal defect in the right side which is respecting a vertical midline. So in fact, this is a bitemporal hemianopia where one side is affected more than the other, right? So again, if you say bitemporal hemianopia, where would you localize the lesion? Optic chiasm. Now let's analyze it a little further. If the defect is more inferiorly, or if it starts inferiorly, that means that chiasm is getting compressed from above. If you have these temporal defect which starts superiorly and goes to inferior, then the chiasm is getting compressed from below. Okay, this is a dictum. So because of the arrangement of fibers in optic chiasm, so here you have defect which is predominantly inferior or has started inferiorly. So chiasm is getting compressed from? Chiasm is getting compressed from above or below? Above, because there is an inferior defect here. So there is, now we have got one more data point. We say that patient has a chiasmal defect and there appears to be a disease process which is above optic chiasm, compressing optic chiasm from above, and that's the reason why patient has a bitemporal hemianopia which is more dense inferiorly. Clear? Now I told you that this is what kind of defect is this? It's an arcuate defect. So arcuate defect is produced by an optic nerve problem. I told you optic nerve problem can cause central scotoma, centrosical scotoma, arcuate scotoma, generalized reduction of sensitivity, complete depression, or altitudinal defects. These are the defects that you'll find in an optic nerve lesion. So what it tells you is that apart from the bitemporal hemianopia, there is also an optic nerve problem on the right side. So looking at this field, what it is telling you is that chiasm is getting compressed, and that chiasm is getting compressed from above, and that compression is extending a little bit towards the right side. So the right optic nerve also is getting pressed. Apart from the chiasm, the right optic nerve also is getting pressed. And so you still localize the lesion to optic chiasm, but this is little more detailed localization, and that's what that patient had. What is this? What is this? So this is seesaw nystagmus. See, one eye goes up, the other eye at the same time goes down and extorts. So the eye goes up and intorts, at the same time the other eye goes down and extorts, and the cycle repeats. So that's why it's called seesaw nystagmus. Also a feature of chiasmal compression. All right, so that's about the chiasmal compression and what are the associated features. Let's look at one more case. This is a 28-year-old female. She's a little obese. She has been having this difficulty in vision for the last 6 weeks. She has been having headaches associated with this dimness of vision. Her visual acuity is 624 in the right eye and 6.9 in the left eye. Her fundi look like this. What do you think? A 28-year-old female, slightly overweight, with gradual dimness of vision for last 6 weeks associated with headache, visual acuity 624 and 6.9, and there is this. What do you find in the fundus now? Basically, there is a bilateral disc edema, right? Now, first, when you see a patient with a swollen disc, your first thing is it's a disc edema. What is papilledema? What's the difference between disc edema and papilledema? Please remember, papilledema, you will use the term only if you know that the disc edema is because of raised intracranial pressure. It is not a synonymous with a disc edema. Disc edema seen in raised ICP is called papilledema. So any disc edema is not a papilledema. So what you find here is a bilateral disc edema. Now you have to work towards it. Bilateral disc edema in a 28-year-old female who is slightly overweight, has a gradually progressive loss of vision. Most likely this is raised intracranial pressure and papilledema. Okay? Because other causes of disc edema like optic neuritis generally would be unilateral, would produce an acute loss of vision. Ischemic optic neuropathy is not very common in a 28-year-old female. So you are probably looking at raised intracranial pressure in this patient. What are the other points in the history you'll ask for? You are suspecting raised ICP. You need to ask the patient the history, examine the patient to say, yeah, clinically, I am now convinced this is raised ICP and I have to now do the investigation accordingly. So what are the other associated feature symptoms that you'll ask for in this patient? Yeah, vomiting. Anything else? Headache is there. Patient says that patient has headache. Anything else? Remember, a very typical feature, a lot of times we miss out, and we should be the people who should be asking it, is transient visual obscuration. Patients with raised ICP typically will tell you that they have transient visual obscuration. Any idea as to what is the characteristic of transient visual obscuration of raised ICP? Transient visual obscuration, there are three groups of disorders which can come to you with TVO, transient visual obscuration. One is raised ICP. Second is vascular insufficiency. Patient has vascular insufficiency anywhere from the heart to the retinal artery. Patient would have transient visual obscuration. And the third transient visual obscuration of phenomena can be seen in migraine. So just by asking history, you can with reasonable surety differentiate between these three. Transient visual obscuration seen in patients with raised ICP generally would last for few seconds. So the characteristic of transient visual obscuration in raised ICP is that it lasts for few seconds versus TVO of a vascular insufficiency which lasts for few minutes. TVO of migraine lasts for half an hour or more. All right? So TVO lasting for few seconds, you are looking at raised ICP. TVO lasting for few minutes, you're looking at vascular insufficiency, and TVO lasting much longer is seen in migraine. The other characteristic of this transient visual obscuration is generally in a vascular insufficiency, patient will say that everything, there is a blackout. While here, in patients with raised ICP, typically they will describe that everything is becoming brown. So there is a browning out of vision, so is to say, versus in a TVO where there is blackout. Okay? So patient will say that everything is becoming brown, and typically TVO, transient visual obscuration associated with raised ICP, is posture related. Generally, when patient gets up from a supine position is when she'll get it. So remember, other symptoms that you'll ask for in a raised ICP, apart from projectile vomiting and headache, would be transient visual obscuration, typically lasting for a few seconds, described as browning out of vision, and associated when patient changes the posture, when she gets up from a supine position. What is the other symptom you'll ask for? Other typical symptom of a raised ICP in these patients would be tinnitus. So patient will have a whooshing sound in ear, right? And these are much more typical. A lot of these patients may not have projectile vomiting. Projectile vomiting and a raised ICP generally you'll see in patients who have associated meningitis. And those patients typically don't come to us first. We get called to see these patients in neurology ward. But when the patients come to you, it's less likely. It's not that it cannot be seen in a non-meningitic raised ICP, but it's much more typical in raised ICP due to meningitis. So the patients who come to our OPD, you'll ask for headache, you'll ask for transient blurring of vision, and you'll ask for tinnitus. Okay, clear? So these are the associated symptoms that you'll ask for. what examination, now what test would you do? Patient has come to you, she is sitting in front of you saying, I'm having a lot of headache. I also have reduced vision now. What would you do next? MRI of hip joint, brain in orbit, with contrast. Anything else? Please remember, an undiagnosed papilloedema which you are seeing for the first time, is an emergency. Why would you say it's an emergency? In fact, in the US, where one of the most common lawsuit is because of raised ICP and papilloedema. Because, so there is a saying, dictum there, that sun never sets on papilloedema. You find a papilloedema, you investigate before you move forward on the same day. Why do you say that? Is because raised ICP, which is because of tumor in the brain, because of space occupying lesion in the brain, can quickly raise the pressure and can cause brainstem herniation, which can be fatal. That's the reason why in the older textbooks you would find that they'll say that lumbar puncture is contraindicated in patients with raised ICP. It's not contraindicated in all patients with raised ICP, but it is contraindicated if you know that raised ICP is because of space occupying lesion or brain tumor, because there are chances of brainstem herniation which can be fatal. So that's the reason why you see a patient where you're suspecting raised ICP, and this is the first time that anytime somebody has suspected raised ICP, first thing is to get the neuroimaging done immediately. The imaging of choice is always MRI brain in orbit, but a lot of times here in an emergency you want to rule out a space occupying lesion. So even if the CT scan is available, that's good enough to make sure that there is no brain tumor. Once you know that there is a raised ICP but no brain tumor, no space occupying lesion, you have some more time to work up the patient, right? Then the investigation of choice is MRI brain in orbit with something else. Would you request your radiologist saying, I'm suspecting raised ICP? So nowadays, almost all radiologists and neurologists would also do something else. So MRI brain and orbit with, in most instances, MR venogram. Okay, why would you look for MR venogram? Because what are you looking for in MR venogram? What are you looking for in MRV? You're looking for thrombosis of venous sinuses, which is now supposedly a cause or an effect of raised ICP. So you see a patient with raised ICP, first thing first, rule out space occupying lesion. Then if you say there is no tumor, that means this is a raised ICP, which was initially, or in the olden days, was called benign intracranial hypertension. Please don't use that term, because that condition is not benign. Patient can potentially go blind. So now the new term is either pseudotumor cerebri or IIH, idiopathic intracranial hypertension. No BIH, IIH. So you want to now rule out IIH. So IIH is idiopathic, so it's a diagnosis of exclusion, and that's the reason why you ask for MRI brain and orbit with MRV. And if you find that there is a stenosis of a sinuses, then neurologist will deal with differently. If there is no stenosis, this is IIH, neurologist will deal with it differently. It's a systemic disorder of the brain, so neurologist would deal with it, but our job is to guide the neurologist as to what is the effect of the treatment that the neurologist has instituted. So what tests now from our side you will do? You have ruled out the tumor, and now you have to follow up the patient. So what test would you do typically? One thing that we all do for all patients is you check visual acuity. This patient already has a little loss of vision. How would you follow up? What are the other tests that you'll do? Color vision, visual field, and nowadays patient is also being advised for a follow-up OCT RNFL. OCT in a patient with disc edema is useful for two things. One, it can differentiate between a pseudo-disc edema and a disc edema. It can differentiate between optic nerve drusen and optic disc edema. Now there are clear-cut diagnostic criteria by which you are able to differentiate between the two. Ultrasound still remains a gold standard if you find a calcification there, but OCT is slowly gaining ground to differentiate between pseudodiskedema and a diskedema. The other advantage of OCT is that you have an objective assessment of optic disc and you can monitor the progression of your treatment. You find somebody who has an average RNFL which is very high and slowly it is coming down, you know that your treatment is functioning. Apart from an obvious reduction of optic disc edema on fundus, you also know that optic disc is slowly becoming better on OCT as well. All right? So these are the tests that you will do from your side. You also, these are the treatment for patients who you diagnose as having idiopathic intracranial hypertension. Weight loss. If patient can lose, a lot of these patients are overweight. So if they can lose 20% of their presenting weight in 6 months, that in itself can bring the intracranial pressure down. So target is to lose 20% of, so if patient's weight is 100 kg on presentation, within 6 months it should become 80 kg. They should reduce 20% of the baseline weight on presentation in 6 months, which in itself can cause a lot of, it can help the patient. There are drugs which are associated with raised intracranial pressure, and those history has to be taken. The typical drugs are oral contraceptive pills or other hormonal treatment which is typically given for polycystic ovary disease and other things. So ask for the history of any of these drugs that patient is taking and stop those medications. The cornerstone of the medical treatment for raised intracranial pressure is acetazolamide. A lot of times neurologists give a dose which is not enough, right? 500 milligram a lot of times would not have an impact on raised ICP. You can go up to 2 grams or more in these patients if they tolerate it. All right? So if the patient is tolerant, then you can go up to 1.5 gram or 2 grams before we say that, yeah, acetazolamide is not having an impact. What are the surgical options for raised ICP? What surgeries would you offer to the patient? Sorry? There are 2 different surgical procedures. One is the shunt procedures, which is typically done by neurosurgeons, and optic nerve sheath fenestration. It has been going up and down in favor. A decade ago, it was the procedure of choice. Then slowly it lost ground. Patients, the surgeons who are doing optic nerve sheath fenestration found that this is a very temporary procedure. The opening that you make in optic nerve sheath typically can get blocked, and the patient can have scarring of the optic nerve with a resurgent disc edema. So optic nerve sheath fenestration is done in patient who has a rapid loss of vision because of raised ICP and is not responding to the medical treatment. Now if the visual function is stable, but patient has a headache, which is the main prominent symptom, and if that is not getting relieved with acetazolamide, then a shunt procedure is what a neurosurgeon will do. So if headache is a predominant symptom, then a shunt procedure is done. If a rapid progression of vision loss or a loss of optic nerve function is a main problem, then a nerve sheath fenestration will be done. So that's about raised ICP. Let's look at now some ocular motility. I've already told you what this patient has. What is the first impression? Patient looks to the left. What do you find here? What do you find here? When the patient looks to the left? Sorry? Loudly. It's quite clear, right? I don't think there is a confusion here. Sometimes the ocular motility can be confusing. What do you find in the left eye? Simple. When the patient tries to look to the left, so there is an abduction limitation of the left side. Okay? What do you find here, right side? There is a nystagmus. Can you see the nystagmus of the right side? Anything else on the left side? There's something here on the left side. What is it? Poor hygiene? No. Scar. Scar, and something is jutting out. What do you think is happening here? There's a little prominence here. You see? There is a prominence here. What is that? If something is implanted, what do you implant? Gold, right? Why would you implant a gold in an upper eyelid? I asked this question when I was doing this PG course in Gujarat, my home state, and a Gujarati business-minded resident said, "Oh, you have implanted gold in the eyelid, that might be for the investment." No, that is investment is in the tooth, not here. So gold weight is implanted in the upper eyelid in somebody who has legophthalmos, right? So what do you now think that this patient has? Patient has an abduction deficit of the left side, nystagmus of the right eye, and patient, I am telling you that gold weight has been implanted because patient had legophthalmos. So legophthalmos occurs because of what nerve? Which nerve? Facial nerve. So you have a sixth nerve, you have a seventh nerve. Which area in the brain these two nerves are together? Pons, medulla. Pons, yes. Any other area? There is a nystagmus of the other eye. If any of you who attended the morning lecture by Dr. Sandan Gopal, he was mentioning how oculomotility is calibrated, and there is one area of the brain which is very important for this. That is cerebellum. Right? Cerebellum follows the orders which are given by the prefrontal cortex and other areas in the brain to see how much the eye should move. So cerebellar disorder or cerebellar problem would typically result in nystagmus because brain is not being able to compute how much eye has to go. So now you say that sixth and seventh now and probably cerebellar sign. So that's the other area where sixth and seventh now are together. What angle? Cerebellopontine angle, right? So this patient had a CP angle tumor. Commonest CP angle tumor is acoustic neuroma, which causes sixth and the seventh nerve and a cerebellar sign. Now see another abduction deficit. See again, this patient also has a gold weight on the right upper eyelid. So I'm telling you that this patient also had a seventh nerve problem of the right side. Now this is how it looks like when patient tries to look to the right. What do you see here? When the patient is trying to look to the right. Now patient is trying to look to the right. What do you see? Is there an abduction of the right side? Yes or no? No. And what is happening to the left eye? See, he is trying to look to the right. There is no adduction also of the left eye. Patient is not able to look to the right. In other words, patient has a right gaze palsy. A right gaze palsy with a facial nerve is what you will find in somebody who has a pontine lesion. So sixth and seventh nerve are together in pons where sixth nerve nucleus is there or at CP angle. In CP angle you will find a cerebellar sign. A lot of times you will find a nystagmus. In pons where there is a sixth nerve nucleus with PPRF. What is PPRF? Parapontine reticular formation. So PPRF with sixth nerve controls the gaze to the same side. So this patient had a right pontine lesion. That's the reason why there was a right gaze palsy. And because if you remember around the sixth nerve nucleus, something goes around. Seventh nerve, all right? So if there is a nuclear lesion, there is a nuclear lesion of the sixth nerve, also the seventh nerve, and this is what you'll find. So if you find a patient with abduction limitation, you want to find out whether this is a pontine lesion or whether this is a CP angle lesion. Pontine lesion would have gaze palsy of the same side. CP angle would have, in the other eye, you'll find a nystagmus. The other eye will move properly but would have a nystagmus. And this is the third video of an abduction limitation. What is the first impression? Esotropia, exotropia? Esotropia of which eye? Right eye. Now see carefully what happens when the patient looks to the left and to the right. This is patient looking to the left. What do you find here? Abduction limitation of which eye? Left eye. Look at the left eye carefully. See when the patient tries to look to the right. No abduction of the left side. See, tell me what do you find about the adduction and elevation? What do you think? So there is a limitation of elevation as well of the left eye. Look at the adduction also very carefully. So why there is a right esotropia here? You had a problem with the left eye not abducting, right? So why there is a right esotropia? Yeah, so why left eye is not, why there is no left esotropia? Because patient, the left eye is a dominant eye. Patient is fixating with the left eye, that's why right eye has gone into esotropia. See here, the adduction is not complete of the left side. So left abduction not complete, adduction not complete, elevation not complete, depression plus minus. What do you think? What do you think? No, so 6 now, because abduction is gone. Elevation, adduction, depression, plus minus. Which now serves these 3? Okay, so partial third now maybe because there is not an impressive ptosis. So if there is a 6 now and a third now, where would you localize the lesion? MLF. If you localize a 6 now and a third now together to brainstem, patient would not be sitting in front of you letting you record, because it's such a huge lesion, generally he'll be in a neurology ward. Okay? So other area where 6th and 3rd now together are closer to the eye, either in the orbit or in the cavernous sinus. How would you differentiate? Ask me one question and I'll tell you, yeah, this is, depending upon that question, the answer to that question, you'll be able to differentiate between orbit and cavernous sinus. One question. No, not pain. No proptosis. Proptosis, yes, good way to differentiate. Anything else? One thing. Just ask me, what is patient's vision? If patient's optic nerve is behaving well, it is cavernous sinus. If optic nerve is not functioning, it is orbit. So when you find a multiple cranial nerve palsy, the external ophthalmoplegia, what Dr. Mukesh also showed you, is generally bilateral. So when you see a bilateral problem, you're looking at either a muscle weakness, you're looking at myasthenia, or you're looking at a supranuclear problem. When there's a unilateral problem, you're looking at probably either a muscle entrapment, muscle fibrosis, or you're looking at multiple cranial nerves. It can present to you in a weird way. This patient had a cavernous sinus lesion of the left side, which was treated, and then patient became normal. So abduction limitation, when the patient comes to you, you obviously look for vision, you look for optic nerve function test, because 6 nerve with optic nerve, you'll find it in orbital lesion. You look for other nerves, 3rd nerve, 4th nerve, 5th nerve. You check for corneal sensation. If the 3rd nerve, 5th nerve, 6th nerve, you're looking at probably cavernous sinus. Then you check for 7th nerve. 6th and 7th together, but other eye moving all right, it might be CP angle. If 6th and 7th nerve together, other eye, the contralateral eye also not adducting, it's likely to be a brainstem or a pontine lesion. Clear? So if you get a patient with a 6th nerve palsy in your exam, you should make sure that you comment about pupil, you comment about the vision, you look at the optic disc. What would you find in the fundus in these patients? What are you looking for in a fundus, in a 6th nerve palsy? Anything? False localizing sign. 6 nerve can be a false localizing sign. In which condition? Remember, bilateral 6 nerve palsy can be a false localizing sign in raised ICP. Somebody who has a raised intracranial pressure can present to you with papilledema and a 6 nerve palsy. It's a false localizing sign. 6 nerve has been affected only because the pressure in the brain is higher. Cavernous sinus thrombosis as well. Now, why a raised ICP you'll have a 6 nerve palsy? Why not 4th nerve? Why not 3rd nerve? Why? Exactly, because of its perilous course from the brain to the eye. It is not because the 6th nerve is the longest. Actually, the 4th nerve is the longest cranial nerve. A lot of times, the answer we get is that, no, because it has the longest course, that's why it gets affected by the raised ICP. No, 6th nerve is not the longest cranial nerve. 4th nerve has the longest course from the brain to the eye, but because the 6th nerve, the way it goes through a very treacherous pathway, because of proximity to the bone, is where it gets pressed against the bone, and that's why raised ICP, 6 nerve palsy can be an associated false localizing sign. All right, so we'll end here and we will break for lunch, and then we'll continue with the next session at 2 p.m. Thank you very much.